everybody, Dr. Deed Harrison here from CBP Seminars and Technique and Chiropractic Biophysics Nonprofit Research. If you've been following these videos, you know that I'm going through a research publication in each one of these presentations, and we're doing it to, number one, make sure that you understand the work that Chiropractic Biophysics Nonprofit has been doing, and number two, also so you don't have to maybe take the time to go source the paper and read it yourself. Some people prefer the videos. However, realize that the video presentations are always more of a cliff note, shorthand presentation, but I also do get the chance to update some things with you as we go with some new publications that may have come out later after the publication that we're going through. This one is a 1997 publication, so this one has been around a long time. However, still, many people have not read this, and there's still controversy in the chiropractic profession and in the physical rehabilitation world with PTs and osteopaths and functional medicine type of specialists. I don't think they really truly understand the nature of the sacroiliac joint. Now, this presentation is not necessarily going to be for patients. Some of the patient presentations that I give, or the research presentations, are more patient friendly when it's a case study or a randomized trial or something like this. This one is just really understanding a unique area of anatomy and understanding the biomechanics and function relevant and relative to treating patient populations through corrective chiropractic methods. So we're going to go through this paper, The Sacroiliac Joint, a review of anatomy and biomechanics with clinical implications. I was the lead author on this with my late father, and then my father's previous colleague that used to work for him in the 1990s. Okay, so this is JMPT, or the Journal of Manipulative and Physiological Therapeutics, 1997, volume 20, number 9, and its pages 607 through 617. So what we'll do is go through a little bit of anatomy, basic review, talk about the structure of this joint with the ligamentous complex and the bony anatomy. Then we'll talk about biomechanics studies, the nature and role of the SI joint. Then we'll try to go into clinical implications and treatment ideas. Now, number one, we have the strongest ligaments in the human body at the SI joint. And we know that the SI joint is the actual only connection between the lower part of the spine, the sacrum, and the ilia, and it is actually a load transmitter of forces from the spine through the trunk down into the pelvis, into the lower extremities. So if we think about this, it's designed to transmit load. It's also designed to dissipate a little bit of the load, like a little bit of shock attenuation, if you will. However, its primary role is to transfer load from the upper body down into the lower body. So if we think about that, mobility is actually going to be a problem if my role is transmission of forces, right? So we've got the strongest ligaments in the human body. The iliolumbar ligaments, people actually don't understand, they play a role in SI joint function. Even though they go from L4 or L5 transverse process, they go over to the iliac crest. There's actually some muscle myofascial attachments into this iliolumbar ligament that act as a joint compressor at the SI joint and a joint stabilizer. What we know is when we section these ligaments out from cadaver studies, it will actually impair the function of the SI joint such that you'll get increased mobility. So we know that these ligaments, although they're lumbar type ligaments, they do play a role in SI joint mechanics and stabilization. And then we have the lumbosacral ligament, which is a very large ligament. We have the anterior longitudinal ligament that plays a very minuscule role, if any. And then we have the big one here, the ventral sacroiliac ligament. That is a huge stabilization mechanism for the SI joint. We have the sacrospinous ligament, which we'll see, that's important. And we also have the sacrotuberous ligament. From the front, those are the ones that primarily support and stabilize this SI joint. From the back, we have the short posterior sacroiliac ligaments in here. We have the sacrotuberous ligament that you get a better view of when we look at it from behind. We have the long posterior sacroiliac ligaments, which are quite important in function for the SI joint stability and also in certain pain syndromes, we'll see. And then we have the the lower attachments of the sacrotuberous ligament as well. So these are my primary supporting ligamentous structures in there. And we know that ligaments are designed to hold or compress joint surfaces together. They do have an inherent tensile load with them. However, what's really needed is an extra load. If I pull on the ligament, then it will force the SI joint structures together. And what we'll see is this is how the muscle system is set up through what's called the thoracolumbar fascia. So we'll see it's really a kind of a load transmission belt system where when the muscles engage, it puts direct linear pull on these SI joint ligaments and it forces the joint surfaces together, creating a compression locking system where this joint becomes very, very stable. Now, even without the muscles, these SI joint ligaments are really, really strong and they're very stable in their support of the SI joint and the human pelvis. And I'm going to go through a couple studies that really clarify that and show how strong this structural system is. Okay? So first and foremost, what we have to understand is the anatomy allows an appreciation of the biomechanics. What are these things really designed to do? Well, number one, I said these are the strongest and largest ligaments in the human body. Point that's very important. Number one, their task is to minimize every movement in this SI joint. It's truly a joint, however, only like the anterior 1/3 portion of the joint is a true what you'd call synovial joint. Okay? Each ligament resists different types of forces due to orientation of collagenous fibers and also their interaction with things like the thoracolumbar fascia. For example, if I were to look at the sacrotuberous ligament, what is this ligament really designed to minimize or limit in terms of mobility? Well, you understand right away that flexion of the sacrum inside the ilia is strongly inhibited by the sacrotuberous ligament. That's what it's designed to do. Now, extension of the sacrum will unload that ligament, so you'll get a slackening in the ligament if the sacrum were to rock back. There's other structures, though, that counteract extension of the human pelvis. So that's a little bit of basic anatomy, ligamentous structure. I'm not going to dive into excruciating detail. We could spend, a whole presentation just on these ligaments themselves. What I do want to do is talk to you about the orientation three-dimensionally of the sacrum itself. And you've got to realize the ilia match this in an opposing manner. This is something we learned, at least most of us, but we've kind of forgotten. Nobody really broke it down, at least in my courses. Nobody emphasized this particular point to me. When I look at the sacrum, it is actually a three-dimensional wedge. Okay? It's a three-dimensional wedge structure that fits inside this human pelvis. And it's designed for great stability the way it's shaped. So if I look at S1 here, it matches the orientation here. So this is the anterior portion of sacrum, segment number 1. This is the posterior portion. And what you'll notice, it's trapezoid shaped to where it's wider in the front or the anterior, and then it's narrow in the back. S2 continues that trend a little more so, but look what happens to S3. You'll notice right away that S3 has an exact opposing trapezoid shape to S1 and S2. This is a very interesting feature of the bony anatomy. This shape is changing its size in the front versus the back as we go from the top to the bottom, and we'll see what that really does. Okay? Then also, this is just down here, this is telling you, what percentage of the joint actually is S1, S2, or S3. And you get the idea that, it's a little bit of S3, it's a little bit of S2, and it's a little bit of S1. So all three of those segments contribute to the SI joint itself, right? So then if I look at this from a three-dimensional perspective, this is the sacrum again, and this right here is the SI joint itself. What we'll notice is we get this propeller shape. This propeller shape is dictated by what I just talked about with these wedge angles here. So the propeller shape lets me realize that, hey, the SI joint is wider in the front at S1, and so this is the anterior position or portion of the joints, S1 and S2. And so you're looking at it from behind right here. So this is the view. They've taken the sacrum and blown it up here. And then At S3, it's narrower in the front and wider in the back. This joint is shaped like a propeller blade on a helicopter or a plane, if you will. Now, you've got to realize the ilia comes in here and connects into that, and the ilia is wider in the back at S1 and S2 and narrower here, okay? So what this allows me to realize is this joint locks together and it's designed to really limit a certain motion. So let's think about this. What motion does this shape limit? Okay? When I add compression load to it from the trunk, it wedges the sacrum in there and it locks it in place. Okay? What motion does this design resist? Well, it resists backwards bending. So it resists extension of the sacrum inside the ilia. That's very important because that's the position that unlocks the wedging shape of the joint and it puts more stress on the ligaments. The bony anatomy prevents that. Okay? If you have any type of compression on this system, the bony anatomy prevents the sacrum from rocking backwards. This is a highly important issue because when somebody does get a retroversion of the pelvis or a rocking backwards of the sacrum, it can be a very serious back pain issue because now I've got bone on bone and I've got anatomy that's going to be impaired in this situation. I get a little unlocking on this mechanism, puts a lot of stress and strain on the ligamentous structures. Okay, so when I have a little compression down and this way, those bones lock together. When I don't, it can rock backwards a little bit. Now taking it a little bit further, this came out in the 1980s, and this is by one of the premier researchers that I would say is really one of the foremost experts on this topic, is Andrew Vleeming. And Vleeming's written many, many papers on the SI joint. First, this came out in the late 1980s in spine, but now you can access this very picture online at, just go to the Journal of Anatomy. It's a peer-reviewed PubMed journal. In 2012, Vleeming and colleagues wrote a beautiful, comprehensive literature review on the SI joint structure and function. And they detailed what I would say is nearly every paper that's ever been done on this topic from a kinematics, biomechanics point of view. They did a fantastic job, and these images are right in there. And it's a free PubMed paper. You can access it, just download it from the Journal of Anatomy. It's a big read, though, by the way. Well, what are we looking at? Well, these are different age samples through the SI joint. This is very important. This is human fetuses, and then this would be adult seniors down here. So we're looking at subjects as they age over time, and we have a cross-section through the SI joint. This is the sacral surface, this is the iliac surface, and you'll notice right away, even in the fetal samples, this joint is not a smooth joint like you would see in typical synovial joints that are designed for mobility. We see that we have opposing ridges and grooves that are changing directions here. Okay, now in the fetal samples, they're quite smooth, not exactly. But as we age, as I get to be upright, weight-bearing, as I put load on the SI joint, these ridges and grooves become very large. Okay, how large? 2 to 11 millimeters in height and depth. So look at this. Previously, and even somewhat today, people look at this and go, that's a bone spur. It's not a bone spur. It's not arthritis. That's normal development of the SI joint in an adult human. The thing develops these ridges and grooves that lock together like this. So you've got the ilia and the sacrum that lock together like this. And you've got to ask yourself, if these are 2 to 11 millimeters in height and depth, that's almost a half an inch. When you go like this, does that thing move? It doesn't move around. Okay? It doesn't move around unless you have serious trauma and pathology. So I looked at this and I read this particular paper and I thought to myself, some of the things that I was being taught are not right. The SI joint doesn't just flop around like this. It's not like a salmon swimming upstream and you can see it wiggle. It doesn't do that. Okay? Now maybe in a fetus and maybe in a newborn, you're going to have some mobility in the SI joint, but it's a tiny little joint. How do you feel it? Right? But as soon as I get upright weight bearing, this thing goes like this and it locks together. 2 to 11 millimeters in height and depth, and they're orientated in different directions. Now here's a surface topography of this. Some of you know what this is, some of you don't. Some of you are backpackers and rock climbers. Well, when I look at surface topography, what I want to do is I go, well, where the lines are really close together, I don't want to go there unless I want to rock climb, because that's some steep stuff. That's a ridge that goes up. You know, maybe I want to climb right here. That looks like a nice little meadow for me to kind of pass through, right? So what this shows you is how the sacrum and the ilia lock together. And look at the way these ridges and depressions are shaped. They're orientated in different directions as we go from S1 to S2 to S3. This joint is like no other joint that's supposed to move in the human body. The joint also has been found to have a relatively high coefficient of friction at the surface that is normal. Once you're in an upright human stance and you're not crawling anymore like an infant, your SI joint is likened to sandpaper at the surfaces. So now you lock the joint together and you've got a high coefficient of friction. It's like sandpaper. As soon as you put a little bit of compression, when you try to move that, what happens? It doesn't move. Take two pieces of sandpaper, stick them together, and try to slide them on each other. It doesn't work, okay? The whole point is this joint is designed to limit mobility. It's unlike any other joint in the body. It's really, really interesting, okay? Of interest, men would have higher coefficients of friction than women. Why? We have a bigger body mass. We carry more loads. So it's proportion. The coefficient of friction is proportionate to the amount of load that you place on the joint. Isn't that interesting? So then, how stable is this structure? Well, let's look at some biomechanical tests that have been done. This one comes from Simonian et al., Clinical Orthopedics and Related Research in 1994. This is a human cadaver pelvis, and it's fixated in these pots here. And then what they can do is they can load with this apparatus here, they can load it into compression, they can add flexion and extension, they can do bending left, bending right, and torsion. Now understand, there is a limit to every study ever done, and I'll clarify this as we go. This is an important part. One of the criticisms of this particular research design was that it doesn't allow freedom of movement of the legs. It's constrained standing. Yeah, I get it, but let's look at how stable this SI joint is in constrained standing. So here's when they loaded it with 400 newtons of compression, 400 newtons of lateral bending and compression, and then here's torsion of 150 newtons of compression, and then 15 newton meters of torsion to mimic, what would happen in upright static stance during different movements. And then here's the true measured displacements at the pubic symphysis under these load conditions. Look at this, 0.03 millimeters. That's how much the pubic symphysis moved. 0.03. You can't even really see that. You have to have computerized, photographic systems to assess this. You're not going to feel that. Externally, I'm going to tell you right now, I don't care if you're a chiropractor, you're a PT, you're an osteopath, you're not feeling that. You're not feeling 0.03 millimeters of movement, I'm telling you right now, right? Here's the SI joint displacement, 0.04 degrees. You're not going to feel that either, right? You might go, oh, well, it moves more when I flex and extend. Really? 0.43 degrees. 0.43 degrees. This thing is designed to be stable. It's not designed to move. It doesn't look like that. And then forgive me, this is where I'm going to get in a little bit of trouble. And I've had little debates with doctors here and there, and they go, well, have you ever looked at a beautiful woman that's walking by and, that's got to be SI joint movement? And I go, no, it's not. It's called rotation and lateral flexion and translation or swinging of the entire pelvis. It doesn't mean the SI joint is moving, right? And women, you could say the same thing about men. I'm not sexist, I'm just bringing up different topics that come up. You watch a man walk, same kind of thing. It's not the SI joint flipping around in there. It's the entire human pelvis that's moving, and it's soft tissue displacement as the muscles are activated. It's not the SI joint that's moving. So then here's what they did. This is an interesting project. They said, well, let's see what happens when we section completely through the pubic symphysis. So the front joint between, the two iliac crests in the front, the pubic rami that come together, they connect at the pubic symphysis. So there's a little joint there. Well, let's see, when I cut right through that, what happens to SI joint stability? Is the SI joint now going to be unstable because I've damaged the anterior ring of this structure? So here it is in the intact, and then here it is with the symphysis pubis cut. And you go, well, look what happened. It went way up. Well, I go, way up? It went to 1 millimeter. Okay? And then here's when they cut the sacral spine, or excuse me, the symphysis pubis, and I believe it was the sacral, I forgot the SI. It's the sacrotuberous and sacrospinous ligament was cut here. Okay, that's what SS and ST means, and I honestly, it's been a while since I read the paper, and you can see I don't remember what SI was, but you get the idea. Even with these ligaments cut, the displacement at the pubic symphysis really never exceeded 1.5 millimeters. And then if I go down to the SI joint gap, let's see how stable it is with these same structures cut. The SI joint gap never even got to 1 millimeter, even when the symphysis pubis was cut, even when the sacrospinous and sacrotuberous ligaments were cut. And for the life of me, I can't remember what SI is. I should have gone back and read that paper. But it's reviewed in the 1997 project that I'm going through here. So the point is here, look how darn stable this SI joint structure is, even when we cut the symphysis pubis, even when we cut some of the supporting ligaments, sacrospinous and sacrotuberous ligaments, the displacement never reaches more than about a degree and more than about a millimeter of displacement. Now that's in upright, leg-constrained standing equilibrium. This should kind of shock you. It should kind of go, wow, that joint is way more stable than I ever imagined. Yeah, it is, right? It's how we run and walk. If the SI joint moved as much as some people think, when you jump on one foot or when you run, your SI joint would shear and your hip would end up to your ear, right? It just doesn't work that way. So this structure is highly, highly stable. So then I'm going to skip ahead because some people have said, well, this other paper that you just went through, it constrained the legs and it doesn't mimic true what we call natural stride and straddle positions, which are theoretically, some people claim, to be associated with the greatest amount of SI joint mobility. So then this paper was kind of a game changer. It came out in the year 2000. And what these authors did is they did true three-dimensional X-ray stereophotogrammetry. So it's three-dimensional computer technology to where with biplanar X-rays we can see the exact 3D kinematics of the SI joint. And what they did is they said, okay, well, let's use the straddle stride position. We'll do this left and right and compare it to neutral. And let's see how much the SI joint moves when we do this. And what they did was even better. They didn't just use normal subjects. They used women that have had, most of them, 5 out of 6 of the women had multiple kids. That's what multiple or M-paridity means. So it means they've had multiple children. In theory, this is the population that would have the largest mobility in the SI joint. Women that have had, multiple kids. So let's see what they found. These are the X, Y, and Z axis rotations in degrees, and then this is a three-dimensional helical axis of rotation around Bonare's tubercle at the SI joint, approximately. So it's a helical axis of rotation, uses what's called screw theory in mathematics, and it tries to reconstruct the actual 3D axis that all these are occurring around. And there's some evidence to support its use, but also it's not perfect, so you don't know exactly where it's occurring, but it's close. So the point is, look, X-axis rotation, that's flexion and extension, a mean of 1 degree during the straddle stride, 1 degree of mobility. Y-axis rotation, that's torsion left and right, okay, twisting left and right, 0.3 degrees, 0.4 degrees at the right. And then Z-axis rotation, that's lateral bending left and right, 0.5 and 0.4. And the negative just means what direction it's going. Is it going left? Is it going right? And then here's the three-dimensional axis, 1.3 and 1.2 degrees. Stop. 1.3, 1.2 degrees of motion in the straddle stride position. And you're going to tell me you can feel that? You're going to tell me that you can externally palpate and feel that SI joint moving in a patient when the maximum mobility is 1.2 to 1.3 degrees? Just let you ponder on that for a minute. They did another one. This one is looking at what's called Gillet's test in physical therapy and chiropractic. And some of you might look at this and go, Deed, you're bashing us, you're beating us up. You know what? Sometimes a little house cleaning is a damn good idea. It's better that I do it than somebody else out there come in that's not a chiropractor, not trained in this, and then makes us look really bad. You know, this is going on 20 years now, and some of this stuff is still not done right in some of the educational circles that chiropractors and PTs and DOs and whatever manual therapists do. So look at this. Gillet's test, standing, or some people do this seated, where you raise the leg up and you're trying to see, does one side drop down? So the PSIS is dropping down. Also, do I have a weakening of the muscle on one side, the gluteus medius muscle? Some people use it to identify that, and it's actually a good test for that. But the idea here, can you actually identify mobility in the SI joint in single leg upright stance doing the Gillet's test? How much do you really think it moves? You know, before we go through this, this is a 3D X-ray study, okay? 3D X-ray study on proper subjects. How much do you really think it moves? I ask that question when I do lectures and seminars to doctors, and I'm not kidding you. Some of them go 10, 15 degrees, and I go, really? Really? And they think that because they were trained that they felt it. That somebody told them that they could feel it. Now what they felt was soft tissue moving around, like the glute maximus contracting, soft tissue bunching around in there, host of fatty tissue, connective tissue in there. That's what you're feeling. Are you really feeling the joint move? Let's find out how much it moves. Oh, look at this. Mean rotations, 0.1 degrees, 0.2 degrees, 0 degrees, 0.2. This one, the three-dimensional axis, well, maybe that'll make you feel better, 0.7 degrees. And then translations, 0.3 millimeters. Do you really think you're feeling that? And then let's just be, let's have a little more fun. Look at this. Here's the most motion, 1.8 degrees. That's the range. You really think you can feel 1.8 degrees under all that tissue? No way. What you're feeling is not bony anatomy moving. You are not feeling this joint move. It doesn't move like you think it does. It does not do that. The other thing we have to consider, every joint in the human body that's a true movable joint, you know what it has? It has a muscle that attaches on one part of the bone, crosses the joint, and attaches to another bone that's in that joint. So I've got two bones that make up a joint. So then I have a muscle that acts as a primary mover. It has an origin and an insertion across the joint. It acts as a primary movement or primary mover of the joint. Name me one muscle that attaches from the sacrum and goes to the ilia, or attaches at the ilia and goes to the sacrum and acts as a primary mover. Guess what, doctors? You can't. It doesn't exist. There isn't one. There's no muscle that acts as a primary mover of the joint. And you just go, oh my God. I'm getting a little excited here because people don't realize what this thing is really all about. The muscles don't act to move the joint. There's no muscle that acts as a primary mover of the SI joint. It doesn't work that way. What do the muscles do then? They compress the SI joint surfaces together. They create a tension-type system in a tensegrity model, and they transfer load from the upper body to the lower body through two mechanisms, joint compression and tension in a tensegrity model. That's what's been recently shown. Okay? What muscles are involved? Lots of them. The multifidus muscle, lat muscle, glute maximus, medius, biceps femoris, the long head, the piriformis, even the traps and the external obliques, right? What do these things do? Well, I'm going to read and then I'll show you some pictures. Most of these muscles attach to the thoracolumbar fascia. This fascia then connects into all the posterior lumbar and SI joint ligaments. The fascia, okay, connects in there. The muscle contracts, tension is then transmitted via the fascia to the SI joint ligaments, which then create increased compression at the SI joint because they cross the joint surface. The ligaments go from the sacrum to the ilia. When you pull on them, put tension on them, now they compress the joint together. Some muscles attach directly into the SI joint ligaments themselves. Like we'll see, the piriformis muscle has some direct attachments into the SI joint ligaments. Contraction of these muscles creates tension in the ligaments as well that is similar to the thoracolumbar fascia tension system, resulting in compression of the SI joint. So here's the way it works. Example, piriformis muscle. Okay, the piriformis muscle goes from your leg and attaches into the sacrospinous ligament, a little tiny bit into the sacral tuberous ligament, but also into the long dorsal sacroiliac joint ligament. That's the piriformis muscle. When it contracts, it puts tension on this system and it compresses the SI joint structure together. Okay, this is the way it's designed to work. Now you can also, if you're kind of an astute clinician here, you can get the idea, well, what if there's too much contraction in the piriformis muscle? What if there's spasm? Could it then create local inflammation and swelling at the SI joint structure or ligaments there and lead to pain and inflammation? Yes, it can. But it doesn't increase mobility, it decreases mobility when we have that kind of mechanism. There is something, though, that we have to be concerned about with increased SI joint mobility, and I'll kind of allude to this at the end. First, I'm just kind of getting excited and getting you to understand the anatomy here. Now, this stuff's becoming very popular nowadays when you look at anatomy trains and cross-lateral patterns, both the front and the back. Well, that's not new. This stuff has been around since the 1980s. Specifically, even in the 1990s, Vleeming et al. Were one of the first to do this, Spine 1995. This is the superficial and deep lamina layers of the thoracolumbar fascia. So we're looking at the posterior aspect of the back. This is the latissimus dorsi muscles coming in. Here's the gluteus medius, here's the gluteus maximus, here's the external oblique muscle, so you get the idea, right? So these muscles come in and they tie into the thoracolumbar fascia. Well, then look what happens. The lat, for example, on the left side, if you follow the fibers, it crosses over and it ties together with the gluteus maximus muscle on the opposite side, the right side. So if you think about this, when I have activation of the upper extremity muscle on the left and the back muscle on the left, it creates compression at the right SI joint. Why is that important? Well, that's how I walk. When I walk and I load my right leg, my right gluteus maximus is contracting. I'm standing on my right leg. My arm is going to swing backwards on the left, and my leg is going to swing forward on the left. This is the dynamics or the kinematics of walking. Okay, so what happens is my left upper body back muscles are contracting, which then compresses the SI joint ligament on the right, the SI joint structure on the right to create stability in single-legged stance. It's how the system's set up. So we get the idea when I look at this, I go, wow, these cross-lateral mechanisms are highly, highly sophisticated and very important for SI joint stability. Such that, here's the kicker, in true chronic low back pain, we can get atrophy of this system. We can get fatty infiltration into the thoracolumbar fascia and weakening of this entire support system. There's no tension transmission and there's no compression of the SI joint structure itself. And now I have a problem with increased mobility. Okay? Now, I don't know if you can truly measure it clinically because the motion only goes up to about 3 to 6 degrees in some of these, really bad chronic low back pain cases. And it's not a condition that really you should be, forgive me, chiropractors, you don't want to manipulate the SI joint in these situations. What you want to do is enhance the stability of the SI joint. The system is broken down. It's not about adjusting the joint back into place. It's about increasing the stability of the connective tissues there. And we have to do it using cross-lateral patterns and cross-crawl training and things like the bird dog. And there's a host of videos that you can go to and look these up. I shot some videos myself. If you go to the Ideal Spine Health Center YouTube channel, you can look up the bird dog series where we show you some simple prone type of cross-crawl maneuvers to do, and then we show you more advanced ones, oblique sideline, and also upright stance to increase the stability of the SI joint. In the end, this needs to be done in people. Walking is a very important way to do this. Cross-country skiing. If you remember the 1980s and 90s, the Nordic track system that was out there. I've had patients over the years that really just had severe atrophy, fatty infiltration of the thoracolumbar fascia that you can see on MRI. And it's like, here's what you need to do. You need to buy yourself a Nordic track, and you need to start with a few minutes per day, and then you need to increase up to where you're doing 30 minutes to an hour a day, and do it, a couple times a day, and don't stop. Once you get rehabilitated, you can go back to 3 times a week. Nordic track should make me one of their PR reps, right? I don't even get kickbacks from them. So this is just showing you how the system's set up to work in these cross-lateral mechanisms, both externally and deep internal layers. And realize there's also unilateral support, but this cross-lateral pattern is perhaps the primary supporting mechanism, the strongest of the systems, right? And so, of interest, here's the thing that's frustrating. And I don't want to just be, critical, but I do want to put this in perspective. The frustrating thing, it's very difficult to identify true SI joint dysfunction in people. Like, there's a host of 12 to 20 tests that chiropractors and PTs and DOs, manual therapists go through to go, oh, true, yep, you've got SI joint problem, or SI joint dysfunction. Well, the reality of it is, when you look at studies, for example, Spine 1996, the value of medical history and physical examination in diagnosing true SI joint pain, it's unreliable. The gold standard is, if you inject the joint with a painkiller like lidocaine and your pain goes away, then the SI joint is what the painful source was. So they compared all these things, history and physical exam findings from trained physicians, trained manual therapists, to a true joint injection. No test and no ensemble of tests could predict the response of a person to a joint block. That's the frustrating part, right? And I don't mean, don't try and don't listen. There are a few tests that are better than others. But in this particular project, they were like, hey guys, you can't predict who's going to respond to it, right? And they didn't try every one, but they used 12 different tests. Now here's the reality, though, of interest is the SI joint and the surrounding ligaments. Are they a source of chronic back pain and leg pain? Yes. Hell yes. They are a big time source of back pain. The frustrating thing, SI joint pain can go anywhere from your hip all the way down to the foot. When your SI joint is injured, the ligaments are swollen and inflamed, and when the system's not supporting itself right, the problem is you can't go, oh, it hurts right there. It could hurt anywhere from your hip down to your foot. And also, here's the back pattern. It could be the posterior buttocks area all the way down to the bottom of the big toe. This can be SI joint involvement. This is the frustrating thing. There won't be true what we call sensory and motor dysfunction, like when I do sensation on somebody, they'll still feel it. When I do pinprick, they'll still feel it. Their gross motor skills or motor function still intact, but the pain will be in these distributions. This is quite challenging for a clinician to figure out. It's also very challenging for a patient to understand. The patient goes, well, I hurt in my leg and my butt down to my toe. How come you're telling me it's my SI joint? My other doctor says it's a disc herniation and a nerve root. And we're like, you don't have nerve root compression signs. It's actually just what we call sclerotogenous pain, right? It's sclerotogenous pain. It's referred from these SI joint ligamentous structures. It's not like a classic nerve root involvement. You don't need surgery for this, okay? At least classic disc surgery, right? So here's what they said. These 12 tests are basically invalid. They might be repeatable and reliable. I might be able to get the same finding as a clinician over and over again, but do they really predict who has SI joint dysfunction? The answer is no, according to this paper, right? So this is a big issue, a big topic. I'll try to touch on this again and tell you my personal perspective on this. Okay, so the other thing, as a manual provider, a chiropractor that likes to adjust the spine, muscle spasms and strains are logically treated by manipulative therapy or adjusting, right? So if somebody has hyperactivity and spasm there, adjusting the joints, the lumbar spine, applying forces to the SI joint structures is logical. You're not repositioning the SI joint. There's no evidence that the SI joint can cavitate or pop, right? Cavitation, the sound that we hear when we do an adjustment. That's actually called a cavitation in physics. It's a rapid change of fluid pressure across a joint surface, right? It's exchange of synovial fluid and carbon dioxide in the joint, okay? The SI joint, there's no evidence that it will cavitate. There's none, okay? In fact, the evidence is that it's when you put your hand there, it's actually the L5-S1 facet joint that is likely cavitating, right? So here's the L5-S1 facet joint. Here's the SI joint. Like, which one is really mobile? Which one's designed to move? Well, it would be the zygapophyseal joint, the facet joint. Are we really manipulating the SI joint? According to Snyder, who is a chiropractor, and I believe he's got his PhD now, it's quite possible that a doctor delivers what he or she believes to be a specific SI joint manipulation or adjustment, but which really causes movement of the lumbosacral facet joint instead. In the clinical setting, most joint manipulation is probably not as specific as we tend to believe. So when you hear or feel this, it's likely the L5-S1 facet, or it could be what's called the accessory sacroiliac joint. Okay, this is an interesting topic here. And forgive my little comments because I train doctors and students. And there's one particular doctor who I trained that just couldn't get over this topic. And in fact, it kind of ended our relationship because he's like, oh, I know I moved the SI joint. It went right under my hand. And I go, really? Here's your hand. That facet joint's right there too. But it also may very well be what's called the accessory or axial sacroiliac joint, which is right here. It's a connection between this part of the iliac crest and the posterior aspect of the sacrum, sacral ala here. So right here, superficially, in 50% of the population, there can be a tiny little joint, and it has actually been shown to be a synovial joint held by loose connective tissue. That joint may be what you're feeling cavitating. It may open up just due to deflection of the iliac part of that sacrum and iliac connection. Keep in mind, it's not the SI joint. It'd be what's called the accessory sacroiliac joint or axial. It's right there if you can see the arrow on the screen. Yep, it's right there. Whereas that's the SI joint. So I had fun reading all this stuff, and then my paper that I'm going through here, 1997. This one came out in 1998, and for me this kind of sealed the deal, but nobody believed it except for weird researchers. Manipulation of the SI joint does not alter the position of the joint. Right? Can the SI joints be manipulated? Can they actually change shape with a thrust type of maneuver? And the answer was no. They looked at people under three-dimensional X-ray analysis, and they found out that 10 patients with SI joint pain diagnosed and treated by a manual therapist before and after 3D positioning or 3D X-ray, none of the patients had a change in position of the SI joint. However, the patients felt better. Well, that's the story of our lives. The patients felt better because of the effects of joint manipulation and soft tissue manipulation. It's not because of repositioning the SI joint itself, right? And this is, you might look at this and go, well, that's a semantics thing. No, it's not. You don't want to fool yourself that you're, taking a pelvis that's twisted, like at the SI joint, and then you're correcting it back into place. It doesn't work that way. Just think about that. If it was designed to do that, every step you took would dislocate the SI joint, every one. It's just ridiculous to even believe that, right? It's totally ridiculous. And then in somebody that has chronic SI joint pain, we don't just want to think about manipulating the joints in the lumbar spine and trying to apply forces to the pelvis. You want to think about rehabilitating the muscle system. You want to rehabilitate the cross-lateral support mechanisms. You want to re-educate this person on what they need to do, right? They have to do activity designed to promote stability across the SI joint. Another thing, here's one that I like to use, and I would argue that there is validity for this particular test. This was not one of the 12 tests that was studied. Now, a classic example of when this applies is in, third trimester pregnancy and greater. It also applies in chronic low back pain patients. Here's the deal. When you sit in quiet stance, if your SI joint system is weakened, when women get pregnant, they release a hormone called relaxin. And the muscles now have to support even stronger because the ligaments are slowly starting to stretch to get ready for, childbirth, right? Ready for that pelvis to open up a bit. Here's the deal. Women will now get a lot of SI joint pain, dysfunction, and that pain can go from the low back, lower butt, all the way down to the foot, right? Well, what happens when you look at the myoelectric activity in the muscles, they're very, very high. So this is the EMG activity in the muscles when they sit. Well, if you'll cross your legs, which forces the SI joint to be supported and compressed together, what happens is that takes pressure off the muscles, it quiets them down, and that also takes pressure off the ligaments, okay? And then the person's back pain feels better. Now in pregnancy, many women respond to what's called a trochanteric belt. The trochanteric belt, by name, goes across the greater trochanters of the femurs, and that belt gently compresses the system together, enhancing stability of the SI joint, takes pressure off the muscles, which takes pressure off the ligaments, which helps with this dysfunction of the system. And women go, wow, that feels really good. And it's because their body is getting ready for childbirth, and the system is stretching out with the ligaments, and the muscles are creating more load, more tension on the ligaments, triggering pain and inflammation. Well, women need to do some cross-lateral work. They need to do these bird dog things that I was talking about. They also can respond very nicely to a trochanteric belt. So here's the deal. You can either use a belt, or you can cross your legs and squeeze your hips together and see if that actually supports your low back and supports your pelvis. And if you feel better when you do this, likely speaking, you have some kind of SI joint involvement. It may or may not be the primary issue, but it's indicative of the fact that you have an SI joint problem. So a trochanteric belt, or crossing the legs, squeezing them together, supports the SI joint system into its compression position that's supposed to be occurring there. If that feels better, you likely have some SI joint dysfunction, and you need to do some proper rehabilitation of this system. The last thing I want to touch on is alteration in posture. This is a big one for us. We know that the SI joint is a highly loaded structure. We know that its kinematics and anatomy are quite complex. The system can be overloaded. You have muscle spasm. It can put too much pressure over time, creating localized pain and inflammation. Well, altered posture can do the same. Like, for example, if you spend too much time in a seated position, which rocks the lumbar spine backwards, it unloads the compression system at the SI joint, and you rock backwards, and it might unlock that propeller shape that's designed to prevent the extension. When that kind of unlocks just a little bit, it can put a lot of stress on some of these SI joint structures, the ligaments. That can lead to pain and inflammation. So people that have a lower lumbar kyphosis and what's called pelvic retroversion, a rocking backwards of the sacrum and the pelvis, that can create a lot of SI joint pain. So one of the primary things that we look for on people is x-rays, and we look at, do you have a loss of your lower lumbosacral lordosis? And if you do, that can put a lot of pressure on the SI joint structures themselves, okay? So keep that in mind. And then altered trunk positions. Hey, your torso is a huge percentage of your body mass. So my torso containing all the internal organs, if that torso shifts over one way, tips one way, or turns one way, and that's what you have in your posture, when you then walk and move from that position, it creates altered kinematics, altered movement patterns, which then loads the joint asymmetrically left and right, which then can trigger a dysfunction to develop. You can get localized pain and inflammation. You can get one side that's not working properly. You can get one side that's working too much. So altered posture is a very important thing for clinicians to look at the SI joint. We've got to realize this, and I'm going to use this particular study to go through the concept of altered loading at the SI joint. This is a holographic analysis of the human pelvis that came out in 1991. And basically what they showed is when you have eccentric loading, non-centric loading at the sacrum, from whatever you have. Maybe you have an anomaly, maybe you have altered posture of the trunk, maybe you have altered position of the pelvis, like a short leg or a twist, whatever you have. When I then apply compression loads, those loads are not distributed equally left and right. So this holographic analysis shows me how the load is transferred from the SI joint down through what's called the arcuate line, down through the hip, into the hip acetabulum. And you'll notice right here, there's no load lines. Is that just an error? Or is load missing in there? And then there's a lot of load over here. So you look at this, you go, whoa, what's going on? No load. Well, that's because I've got this eccentric load scenario where this side is highly loaded. It's receiving more of the compression stress, and it's transferred down to this side, whereas this side's not getting enough. What could happen over time? Well, two things can happen. This side's too highly loaded. You can get things like hip osteoarthritis. You can get early degenerative arthritic changes at the SI joint that develop from too much load. You can get calcifications of some of the ligamentous structures. What about over here? You can get osteopenia. Osteopenia, or a mild form of osteoporosis. Have you ever wondered why, oh, I got osteoporosis genetically of my right femur? Give me a break. Genetic right hip osteoporosis? Just in the right hip? Come on. What about the left? It just decided not to go there? Like, geez, come on. Some of this stuff, you got to look at it and go, common sense has been neglected in healthcare, right? Yeah, you might have osteoporosis, but why is it affecting one side more than the other side? Maybe it's because of the way you're doing activities. Maybe it's your position. Maybe it's your load scenario, right? Mechanics dictates lives. It's called mechanobiology. There's a whole field on it now, right? As I get so excited, I'm slobbering. So one of the things we will do with the SI joint is we'll take a look at the sacral surface on an x-ray. And we'll do standing upright weight-bearing x-rays, and we'll look, hey, is your sacrum malpositioned in terms of, do you have a short leg? Do you have a true anomaly of the sacrum? That's what I mean by malposition. Do you have a genetic, tilt in that sacrum and it grew funny due to, whatever, altered loads or altered genetic bone profiles, right? Developmental profiles, which both play a role in bony development. So I look at this and I go, hey, this person, their sacrum is tipped low on this side. It's an anatomical leg length inequality. Let's put a shoe lift in there, a proper orthotic. Let's get the system level, and let's get you walking normal and standing normal. This helps out with SI joint dysfunctions in theory, right? So think about that. The conclusion of the article is, look, the anatomy and biomechanics is quite complex, quite sophisticated at the SI joint. I think an understanding of the anatomy leads to an understanding of the biomechanics, which also leads to an understanding of how this system is truly designed to work, which then leads to an understanding of proper care for people that need it, right? If I really understood all this information that I just kind of breezed through with you, clinically, then I can take that and I can package it and I can come up with a proper rehabilitation program for patients that truly have SI joint dysfunction, SI joint involvement in their pain syndromes, And it's much more complex than just the theory of adjusting a joint back into position at the SI joint. It doesn't really work that way. We've got to look at this as a proper system, support system, myofascial ligamentous complex, and we've got to learn how to treat it effectively, and a lot of that includes proper rehabilitation. Hopefully you enjoyed this presentation. There's a lot more to it. I would suggest you read the article that I wrote in 1997 with my colleagues, or go to the Journal of Anatomy 2012, the Vliming article. That's a fantastic article, actually way better than my 1997 report, if I do say so myself. So until next time, please continue to watch these videos and support Chiropractic Biophysics nonprofit research. Thank you.